Welcome, knowledge seekers and professionals, to the channel of the Swiss Journal of Radiology and Nuclear Medicine. A quick heads up, the following audio does not include any images, tables, or other additional information. If you're interested in the following paper, please visit our website listed in the caption below. Now, let's get started. Today, we're going to dive into the scientific publication with the title Transarterial Embolization of Visceral Artery Aneurysms, a literature review and two case reports by Nando Martiniet, Carlos Buitrago Teles, Pascal Kissling, Frank Mosler, and Gerd Nolge. Introduction. The inaugural identification and description of a visceral artery aneurysm occurred in 1770, when the French physician Bossier documented such an occurrence in the splenic artery during an autopsy. Aneurysms are frequently discovered incidentally, with a prevalence of up to 6.9% on CT angiography. Stone and others categorized aneurysms in their study of 21 patients, identifying 14 male patients and 7 female patients in the observation period spanning from 1980 to 1998. In this cohort, aneurysms were documented at a frequency of 0.1 to 0.2%. Fisher and others reported an average size ranging from 2 to 3 centimeters in their study involving 144 aneurysms across 131 patients. Pitton and others, in a comprehensive analysis of 233 patients with a total of 253 visceral aneurysms, identified 11 aneurysms in the main trunk of the superior mesenteric artery and its side branches. Notably, the rupture rate in this large patient population was significantly higher for pseudoaneurysms at 76.3%, compared to true aneurysms at only 3.1%. The diagnosis and clinical manifestation of most aneurysms typically occur after aneurysm hemorrhage. Two primary categories of causes contribute to aneurysm development. 1. Endogenic causes. Degenerative arteriosclerotic changes in the vessel wall stand as the primary predisposing factors for the formation of aneurysms or pseudoaneurysms, frequently occurring in conjunction with prolonged arterial hypertension. This degenerative process serves as the primary cause of true aneurysms. Another subgroup within this cohort comprises infections or mycotic aneurysms, with mycotic aneurysms being the second most common etiology. 2. Exogenic causes. Aneurysms may arise following direct vessel trauma, often presenting as pseudoaneurysms. Primary causes include iatrogenic factors such as surgery or punctures, as well as traumatic events like traffic accidents, impact injuries, and vascular penetrating injuries caused by gunshot wounds or stabbings. Treatment. Presently, the available treatment options for visceral aneurysms encompass 1. Surgical treatment. Resection of the aneurysm with vessel reconstruction, potentially performed laparoscopically in specific cases. 2. Minimally invasive endovascular transcatheter treatment. Widely acknowledged as the method of choice, this approach is applied based on interdisciplinary consensus. Within the realm of minimal invasive treatment, options include transcatheter aneurysm occlusion using covered stents or embolization employing macrocoils and microcoils, microvascular plugs, or a combination with liquid embolisates such as onyx. In instances where coil alone closure is inadequate, the packing technique is employed. A newly emerged subset of stents, known as flow diverters, originally from interventional neuroradiology, is utilized to line vessels and diminish flow within the aneurysm, leading to aneurysm thrombosis. Although these devices offer advantages in terms of smaller placement mechanisms and catheters, their widespread use is constrained by their high cost. Preserving vessel flow is achieved through various techniques, including stenting and coiling through the stent struts or balloon-protected aneurysm coiling. While covered stents and flow diverters maintain antegrade flow without embolizing the aneurysm, alternative techniques may mechanically occlude either the aneurysm alone or both draining and feeding vessels if they can be sacrificed. Treatment strategies differ for mycotic aneurysms, necessitating surgical intervention due to the introduction of foreign bodies such as stents, coils, or liquid embolisates being unsuitable for primarily infected tissue. In critical conditions where general anesthesia or surgical procedures are not viable, the minimally invasive endovascular procedure may be the preferred method, even for mycotic aneurysms. Overall, transarterial treatment is currently administered in over 95% of cases, demonstrating both technical and, in many instances, primary clinical success rates of a similar magnitude in patients. In 2020, the American Society for Vascular Surgery issued clinical practice guidelines on visceral aneurysm management. Chair and others presented treatment recommendations based on factors such as type, localization, and the clinical course of the aneurysm. Case 1. In April 2023, a 64-year-old patient presented with hemodynamically significant retroperitoneal hemorrhage stemming from a branch of the gastroduodenal artery, necessitating surgical intervention. Subsequent postoperative CT imaging revealed a 4 mm aneurysm in a mesenteric branch in the upper abdomen, likely corresponding to a side branch of the right gastroepiploic artery. Considering a prior episode of bleeding within the same vascular territory, the interdisciplinary team recommended embolization to the patient. The procedure was conducted electively, commencing with retrograde ultrasound-guided access to the right common femoral artery. Following the insertion of a 6-foot sheath, probing and visualization of the celiac trunk were undertaken using a SIM-1 selective catheter. Selective and superselective visualization of the aneurysm at the vessel branch in the region of the gastroduodenal or right gastroepiploic artery revealed a 3.5 times 4 mm true aneurysm. Subsequently, probing and an attempt at superselective embolization using detachable coils were performed. Due to the anticipated risk of coil dislocation attributed to the wide neck of the aneurysm and its location involving 3 vessel branches, partial anchoring of a 5 mm coil in one of the collaterals was executed. Cautious retraction of the microcatheter facilitated the retrograde placement of the main portion of the coil within the aneurysm. A second 4 mm detachable coil was then successfully utilized to pack the aneurysm. The final control angiography exhibited a densely packed aneurysm sac, devoid of residual perfusion. The anchoring coil segments in the gastric collateral minimally impacted collateral flow. The preserved antegrade perfusion of vessels traversing the aneurysm indicated a technically successful embolization without the threat of ischemia in adjacent vessels. The overall procedure duration was 62 minutes. The patient was discharged in good general condition after 2 days, with unremarkable local findings following puncture in the right groin. Subsequent clinical follow-up revealed no new bleeding incidents. A CT scan performed 4 months post-embolization demonstrated the absence of residual aneurysm perfusion and patent collateral vessels. Case 2. A 68-year-old patient with dilated arteriopathy, following juxtarenal aortic replacement with a Y prosthesis, underwent a series of visceral surgical interventions, including sigmoid resection, multiple laparotomies, adhesiolysis, and ultimately stoma relocation after left hemicolectomy. Subsequent follow-up revealed the presence of a pseudoaneurysm in a branch of the superior mesenteric artery in the right mid-lower abdomen, likely resulting from iatrogenic or clamping damage to the mesentery. After interdisciplinary consultation, embolization was recommended. Retrograde puncture of the right femoral artery was performed using the Seldinger technique under local anesthesia, with the introduction of a 5-French sheath. In the overview angiography of the superior mesenteric artery using a 4 French C1 catheter, an amputated side branch of the superior mesenteric artery was observed. A slow perfused pseudoaneurysm, likely originating from the iliacoelic artery, was identified after superselective catheterization using a 2.4 chain microcatheter measuring 17 times 7 millimeters. Successful selective probing of the aneurysm neck was performed. Peripheral evidence of retrograde contrast in a presumably dissected branch in a small arcade was observed. Coiling of the aneurysm neck was accomplished using a 2/80 millimeter detachable microcoil, leading to immediate occlusion with contrast stasis. Catheterization of the distal retrograde arcade branch was also carried out. Although no perfusion of the aneurysm was visible, the small side branch was coiled using a 2/20 millimeter microcoil. Control angiography confirmed complete aneurysm occlusion without flow impairment in adjacent vessels. The intervention time totaled 56 minutes. Renewed superselective probing of the suspected dissected branch revealed evidence of retrograde inflow just short of the aneurysm. The patient's post-interventional course was uneventful, allowing for discharge after 3 days in an age-appropriate and subjectively well state. A follow-up CT scan conducted 3 months post-embolization demonstrated persistent occlusion of the pseudoaneurysm with a decreasing size, and no signs of coil migration or bowel ischemia were observed. Discussion. Aneurysms and pseudoaneurysms pose a considerable risk of rupture, leading to potentially life-threatening bleeding when they reach a size of 2 to 3 centimeters. In cases of sudden onset bleeding, immediate and efficient therapy, guided by interdisciplinary guidelines and consensus, is imperative. Emergency angiography, performed superselectively with embolization readiness, is considered the first-line treatment, showing high technical success rates up to 100% and a low complication rate of 0.1 to 0.2% for treated ruptured visceral aneurysms after embolization. Before the advent of minimally invasive transcatheter treatments, the primary options were surgical clamping, vessel reconstruction, or resection of the affected vessel. While these methods remain prevalent for mycotic aneurysms, percutaneous endovascular embolization has gained prominence for ruptured aneurysms, exhibiting a 30-day mortality rate of 6.7% compared to 0% for non-ruptured aneurysms. Interdisciplinary guidelines now guide the elective treatment decisions for incidental aneurysms, and embolization techniques have evolved with the introduction of new catheters and guide wires. In cases where the exact bleeding localization can be determined by angio-CT before the minimally invasive procedure, it proves beneficial for subsequent emergency angiography. In critical conditions, emergency angiography can be performed as an overview, followed by selective and superselective imaging to locate the bleeding source, leading to immediate embolization. With the continuous development of endovascular transcatheter embolization techniques, careful consideration is given to the placement of embolization material, primarily coils, alone or in combination with liquid embolics. The risk of complications, such as embolism dislocations causing intestinal wall ischemia, demands vigilant attention. Historical studies by Knowles and others in the 1980s provided insights into vascular compensation mechanisms, emphasizing the importance of superselective placement to avoid complications. In the specific context of the superior mesenteric artery, embolization therapy for aneurysms or pseudoaneurysms has reported high technical and clinical success rates of up to 99.8%. However, careful consideration is required when placing coils, particularly in combination with corpuscular and liquid embolic materials, to prevent the risk of intestinal wall ischemia. Complications in the superior mesenteric artery are estimated to vary between 6 to 15.6%, depending on subcohorts, highlighting the importance of meticulous intervention. Pitcher's recent retrospective evaluation sheds light on the predominance of vascular surgery therapy over endovascular, minimally invasive approaches for superior mesenteric artery aneurysms. Special considerations and challenges are outlined for specific locations, including occluding the celiac trunk in cases involving the pancreatic duodenal artery. Additionally, rare occurrences of aneurysms in Crohn's disease has the importance of tailored treatment strategies. The success of embolization therapy is contingent upon the correct interdisciplinary indication, angiographic expertise, pre-interventional imaging, and the appropriate choice of embolization material based on the anatomical and bleeding characteristics. Covered stents are favored in straight vessel sections, while macro and microcoils, alone or in combination with liquid embolisates, are preferred in cases lacking a suitable anatomical neck. Special precautions must be taken, particularly in cases without a neck, to prevent complications such as embolic material dislocation. The two cases presented here exemplify the effectiveness of embolization therapy when performed with meticulous care and expertise. Conclusion: the decision-making process regarding the treatment approach for an aneurysm or pseudoaneurysm necessitates a thorough interdisciplinary consensus, taking into account the existing body of literature. Currently, embolization therapy or covered stenting stands out as the preferred method. Performed in a minimally invasive manner, this approach boasts methodically determined low invasiveness and exhibits high effectiveness in terms of both technical and clinical success. It has firmly established itself as a key modality within the spectrum of available surgical and minimally invasive therapeutic options. Leveraging advanced technology, state-of-the-art catheters, wires, and comprehensive expertise in various embolization methods, the treatment of acute bleeding in emergency cases has become feasible. However, it is imperative for the radiological interventionist to prioritize vigilance against the risk of over-embolization and the potential complication of embolization material dislocation. This precautionary measure is crucial to prevent such occurrences in every case, as underscored by the experience with our patients. We have come to an end. Thank you for listening in, and until very soon with more interesting publications. If you want to share your own paper in our journal, feel free to contact our team. We are looking forward to hearing from you. Don't forget to like and share if you enjoyed this content. Click the subscribe button so that you don't miss out on future publications from the Swiss Journal of Radiology and Nuclear Medicine. Until next time.